Welcome to this deep dive into the source material. Today we have a really highly specific, remarkably complex medical and mechanical mystery on the table.
Yeah, we're exploring the phenomenon of the unerupted incisor.
Right, and to do this, we're pulling from a pretty dense stack of authoritative sources. I mean, we've got definitive orthodontic texts like Contemporary Orthodontics, the Handbook of Orthodontics, alongside various clinical manuals and surgical guidelines.
It is a phenomenal cross-section of literature. What we are really looking at here is essentially a masterclass in biomechanical engineering, surgical intervention, and pure biological detective work.
All localized right to the anterior maxilla, so basically the front of the upper jaw.
Exactly. It's fascinating.
Because everyone remembers that feeling, right? You lose your front teeth, you put them under the pillow, and you wait for the adult ones to grow in.
It's a universal milestone.
But what happens when that adult tooth simply just never shows up?
That's when the biological machinery essentially halts, and it sets off a massive clinical cascade.
Okay, let's unpack this. Because the texts are incredibly precise about when that delay officially becomes a pathology.
Right. The clinical guidelines establish a very strict baseline. Normally, those maxillary, permanent, central, and lateral incisors erupt between, say, 7.5 and 8.5 years of age.
But clinicians aren't just staring at a calendar.
No, not at all. They are evaluating developmental symmetry. The literature actually flags a delayed eruption under two very specific conditions.
And the first one is bilateral asymmetry, right?
Yeah. If the contralateral tooth, so the matching incisor on the opposite side of the mouth, has been erupted for more than 6 months, you have a definitive red flag.
And the second criterion looks at the lower jaw. So if the mandibular incisors have come in, and more than a full year passes without the upper one showing up, you're no longer just watching and waiting.
Exactly. At that point, you are diagnosing an eruption failure. The biological sequence is definitively broken.
Which means either there's a mechanical obstruction in the way, or some fundamental developmental anomaly has interrupted the path.
And this isn't some super obscure edge case either.
No, incidence rates vary between 0.04% and 2.6% of the population.
Right. The permanent maxillary central incisor is actually the third most commonly impacted tooth,
Trailing just behind wisdom teeth and the upper canines.
What's fascinating here is the pronounced demographic skew.
Oh yeah, the gender disparity.
The literature explicitly notes a male-to-female ratio of 2.7 to 1.
That is a massive difference, 2.7 to 1.
It really is. It aligns with broader discussions in dental anthropology about how craniofacial development and dental anomalies present with different susceptibilities across sexes.
Probably due to variations in the timing of developmental windows or genetic expressions related to odontogenesis.
Exactly. But while that epidemiological data is striking, the literature really emphasizes the unseen biological clock that's just ticking away beneath the gums.
Root formation.
Yes, root development is the primary engine of eruption.
Because normal root formation isn't actually complete when the tooth first pops through the gums, is it?
Not even close. It takes an additional 2 to 3 years post-eruption for the apex of the root to fully close.
So that ongoing growth is what literally pushes the crown down through the bone.
Right. The Hertwig's epithelial root sheath is generating that biological force.
Which means if the tooth is physically blocked and it's trapped in the bone while the root keeps maturing,
that developmental engine eventually just burns out.
the root closes, the force drops to zero, and the tooth is marooned.
That is the core biomechanical crisis. If you miss that window of root development, you lose the body's natural help in moving that tooth.
And beyond the biomechanics, we have to talk about the psychological toll on a kid.
Oh, absolutely. We are discussing the literal centerpiece of the human smile.
For a patient entering early adolescence, a missing front tooth causes severe compromises in dentofacial appearance, low self-esteem,
And localized functional problems. You need those teeth for the anterior shearing action to bite food.
plus the phonetic consequence. The texts highlight a very specific speech impediment.
Right, difficulty pronouncing sibilant consonants, especially the S sound.
Because to say S, your tongue has to direct a narrow stream of air right against the back of those front teeth.
When the teeth are missing, the airflow loses that targeted turbulence and you get a pronounced lisp.
So it's a cascading failure. Phonetic, functional, aesthetic, and psychological.
Which is why the mandate to fix it is so aggressive.
So how does a tooth just get stuck? If the timeline is blown, what is actually causing the blockade?
The sources categorize the culprits into environmental or traumatic factors, hereditary and developmental anomalies, and systemic syndromes.
Let's start with environmental. Early loss or over-retention of baby teeth.
Baby teeth act as spatial placeholders and guides for the adult teeth. If a baby incisor gets knocked out early from trauma or pulled because of decay, the overlying gum can become highly dense and keratinized.
Basically forming a scar tissue roadblock.
Yeah, or the bone reforms over the path, making it too dense to penetrate. And conversely, if a baby tooth just refuses to fall out, it physically deflects the adult tooth.
But the trauma aspect goes way deeper than just losing a baby tooth early. The texts talk extensively about delaceration.
The sheer physics of how a delaceration forms is staggering. It refers to a severe bend in the root of the permanent tooth.
Like a fishhook.
Exactly. And the data shows 71% of these are developmental, but 22% are directly caused by mechanical trauma to the baby tooth.
So imagine a toddler falls, hits their mouth, and drives their baby front tooth straight up into their gums.
An intrusion injury. The tip of that baby root is only millimeters away from the soft developing bud of the adult tooth.
Which isn't calcified yet, it's just a soft matrix.
Right, so the hard baby tooth impacts the soft permanent follicle. It physically knocks the forming crown off axis.
And as it keeps growing over the next few years, the root follows its original genetic path, but the crown is pointed the wrong way.
Leaving you with a tooth shaped like a fishhook, it becomes mechanically incapable of normal eruption.
Because the root architecture just doesn't fit the eruptive path.
But while trauma is significant, the texts highlight that developmental anomalies are the dominant cause, specifically supernumerary teeth.
Extra teeth.
Yeah. They account for 28% to 60% of all unerupted central incisor cases.
Here's where it gets really interesting, because the literature doesn't just lump all extra teeth together. The shape matters.
The morphological distinction is crucial. You have simple conical supernumeraries, which are small and peg-shaped.
They might push things around a bit, but they don't always stop eruption.
Right. But then you have tuberculate supernumeraries and odontomas. Those are the major obstructions.
A tuberculate supernumerary is barrel-shaped, right?
Yes. Barrel-shaped, multi-cusped, and usually their roots don't form well. Crucially, they almost always sit palatally so on the roof of the mouth side of the permanent incisor.
Sitting directly in the pathway, wedging the real tooth against the front of the jawbone.
And because of their mass, the permanent tooth is effectively blocked until you surgically remove the anomaly.
And then there are odontomas, which sound like a complete developmental misfire.
An odontoma is a hamartoma. It's a benign tumor-like mass of dental tissue. Enamel, dentin, pulp.
The texts say compound odontomas look like a bunch of tiny malformed teeth in a sack.
Dozens of microscopic denticles, and complex odontomas are just amorphous boulders of calcified tissue.
Either way, it's a literal rock blocking the tooth.
Exactly.
The sources also mention systemic conditions: cleft lip and palate, cleidocranial dysplasia, or CCD.
Yeah, with CCD, the unerupted incisor is just one symptom of a massive disruption. Patients often have multiple extra teeth, delayed bone ossification.
Least in collarbones too, right?
Yes, hypoplastic clavicles. So if a dentist sees a heavily delayed front tooth, they have to review the medical history for these syndromic indicators.
And the urgency to figure out the exact cause is high, because the rest of the teeth aren't just sitting still.
The dental arch is highly dynamic. If that central space stays empty, the adjacent lateral incisors will rapidly drift toward the midline.
They basically steal the space.
Mesial drift, yeah. They obliterate the arch perimeter. So even if you eventually find the trapped tooth, you first have to undo months of drift just to make room for it again.
With all these hidden boulders and fishhook roots buried in the gums, how do doctors even know what's going on under the surface?
It starts with clinical detective work. The diagnostic protocol begins with basic physical assessment before any x-rays.
Palpating the gums.
Exactly. Tracing the alveolar ridge with a finger, feeling for a labial or palatal bulge. A palpable mass tells you where the crown is hiding.
And they check the baby teeth too, right? If a baby tooth is totally immobile and sounds hollow when tapped.
That suggests ankylosis. Fusion to the bone, meaning it won't fall out naturally.
But feeling the gums only gets you so far. You need imaging.
And the traditional imaging protocol is heavily rooted in 2D intraoral radiography. Periapicals, upper standard occlusals.
But using a flat 2D image to look at a complex 3D problem is a massive headache. You can see the extra tooth overlapping the real tooth, but you can't tell which one is in front.
That spatial ambiguity is the real challenge, which is why the textbooks dedicate so much attention to the parallax technique.
The parallax concept, explain that because it's super clever.
Basically, it relies on how an object appears to move relative to a background when your angle of observation changes. If we connect this to the bigger picture, it's the exact same trick your brain uses for depth perception.
Like when you close one eye, shift your head, and watch a foreground object move against the background.
Yes, dentists use this by taking two separate 2D x-rays of the same area, but they shift the x-ray tube horizontally or vertically between shots.
And the geometric translation of this is the SLOB rule. SLOB. Same lingual, opposite buccal.
Right. If you shift the tube sideways and the hidden tooth appears to move in the same direction as the tube, it's located on the lingual or palatal side, closer to the roof of the mouth.
And if it moves in the opposite direction, it's on the buccal or labial side, closer to the lip.
It's an incredibly elegant way to map 3D space using 2D images.
And it avoids a ton of radiation. Which brings us to 3D imaging, or CBCT, cone beam computed tomography.
CBCT scans are incredible. They give you a flawless, high-resolution 3D volumetric rendering of the jaw.
It instantly shows the exact angle of the delacerated root, the exact position of the odontoma, but the texts are very firm that doctors shouldn't just jump straight to a 3D scan.
And that's because of the ALRP principle, as low as reasonably practicable.
Because pediatric tissues are so sensitive to radiation.
Exactly. Rapid cellular division makes kids vulnerable. A CBCT scan delivers a significantly higher radiation dose than standard intraoral x-rays.
The restraint shown in the medical guidelines is really impressive. Even though the 3D tech is right there, doctors strictly limit it to protect kids.
The burden of proof is on the clinician. You have to try mapping it with parallax first. CBCT is only justified if the 2D results are unclear, or the impaction is so severe that you can't safely plan surgery without 3D data.
You can't just use it for convenience. So once the detective work is done, and they know exactly where the blockage is, the rescue mission begins, the game plan.
And the management guidelines are heavily dependent on the patient's age, specifically root maturity.
Age 9 seems to be the magic number in the literature.
9 is the critical threshold. It differentiates a developing open apex from a closed mature apex.
For kids under 9, the approach is the EUT protocol. SEWT, space creation, extraction of the obstruction, watchful waiting, and traction.
Right. First, you create space. If the adjacent teeth have drifted, the orthodontist uses appliances to open that gap back up.
Then the surgeon extracts the extra tooth or the odontoma.
And then comes the W, watchful waiting.
Which is wild to me. They clear the path and then just wait. Do nothing.
They actively refrain from applying any traction. They monitor the site, relying entirely on the eruptive potential of that immature root.
Because that biological engine is still pushing.
Yes. And the data supports this. After removing an obstruction in an under 9-year-old, spontaneous eruption happens about 80% of the time.
But the patience required here is immense. The literature says it can take 9 to 18 months for the tooth to descend.
Up to 1.5 years of just looking at an empty space in a kid's smile.
I can imagine parents asking, why not just glue a bracket on and pull it down today?
The clinical temptation is definitely there, but bypassing the wait is a mistake.
Because natural eruption preserves the delicate tissues far better than we ever could mechanically.
Exactly. When a tooth erupts naturally, the periodontal ligament, the bone, the gums, they all develop in perfect physiological harmony.
And dragging it down mechanically can cause gum recession or bone loss.
If the body can do it naturally, you have to let it.
But what if they're over 9 years old?
Then the root is mature. The biological engine has shut down. So the SCT protocol becomes the SET protocol. Space, extraction, and immediate traction.
No watchful waiting.
None. The tooth lacks the intrinsic force to move on its own.
So during the surgery to remove the extra tooth, while the patient is under anesthesia, the surgeon bonds a bracket and a gold chain directly to the trapped tooth.
It avoids putting the patient under a second general anesthetic later. The attachment is secured, the gums are closed, and orthodontic traction begins as soon as it heals.
And for late referrals, kids over 10, it's automatic SET protocol, immediate exposure and bonding, which brings us to the actual surgery, going in.
The surgical techniques used to expose the tooth are fascinating, and they dictate the long-term health of the gums.
The literature divides this into open eruption and closed eruption. Let's talk about open first, the window technique, or gingivectomy.
This is for shallow labially positioned teeth. The surgeon just excises a circular collar of tissue right over the hidden crown, leaving it exposed.
But there are very strict anatomical rules for this.
This raises an important question. How do you expose a tooth without destroying the tissue? The answer lies in the type of tissue.
Right, the texts are obsessed with attached gingiva versus alveolar mucosa.
For good reason. The attached gingiva is that firm, heavily keratinized pink tissue right around your teeth. It's built to withstand the friction of chewing and brushing.
But higher up, past the mucogingival junction, is the alveolar mucosa, that loose, stretchy red tissue inside your lip.
An incisor must erupt through keratinized attached gingiva. If you cut a window in the soft mucosa or drag the tooth through it, the tissue just strips away.
Leaving a massive recession defect and an exposed root, a periodontal disaster.
Exactly. So for a window technique, you have to leave at least 3 millimeters of attached gingiva around the tooth.
If the tooth is too high up for that, you use an apically repositioned flap, the ARF.
With the ARF, the surgeon raises a flap of that good keratinized tissue, exposes the tooth, and then sews the flap back down higher up on the tooth.
You physically move the tough tissue to where the tooth is, but the texts note this can make the tooth look longer than the others, an aesthetic compromise.
Which is why closed eruption is often the preferred method now, especially for deep impactions.
So what does this all mean? Closed eruption sounds totally counterintuitive.
It really is. The surgeon raises a flap, glues the gold chain to the tooth, and then sews the gums completely back up over the tooth.
Like a submarine rescue. You attach a cable, seal the hatch, and slowly pitch it to the surface.
That's a great analogy. Only the very end of the gold chain sticks out of the mucosal incision line.
And as you pull the chain over the next few months, the tooth moves through the bone and drags the soft tissue along with it.
It simulates normal eruption. The gum health and the aesthetics end up being vastly superior.
And the mechanics of the pulling force are crazy. You've got heavy base arch wires holding all the normal teeth perfectly still.
Serving as a rigid anchor.
And the actual pulling is done by a nickel titanium or nitty overlay wire.
Nitty is a shape memory metal. It's super elastic. You bend it down to clip onto the gold chain, and it constantly, gently tries to return to its original shape.
A light, continuous pulling force that never gets tired.
And that light force is key. Heavy forces just cause necrosis and actually stop the tooth from moving. Light force stimulates bone remodeling. Osteoclasts clear bone out of the way, osteoblasts fill bone in behind it.
A seamless, biologically mediated excavation.
In 90% of cases, it works beautifully.
But what happens in the worst-case scenarios? When the tooth simply refuses to budge.
Severe complications. This is where we go from routine orthodontics to extreme salvage operations.
Let's go back to delaceration. We mentioned fishhook roots. If that bend is extreme, almost 90 degrees,
You have a geometric impossibility.
if you grab the crown of a bent tooth and pull it straight down into the mouth, the bent root has to swing the opposite way.
Like a lever. And the texts explicitly warn that pulling an extremely delacerated tooth will literally force the root to perforate straight through the labial cortical plate of the jawbone.
The root just tears right out of the front of the jawbone, under the lip. That's horrifying.
It's a devastating iatrogenic injury. This is exactly why a CBCT scan is mandatory if severe delaceration is suspected. You have to mathematically prove the bone can contain the root before you pull.
If it can't, you absolutely cannot pull that tooth.
The other major nightmare is ankylosis.
Ankylosis. This is when the periodontal ligament disappears, right?
Yes. Normally, that ligament acts as a shock absorber and handles the tooth movement. But with ankylosis, the root fuses directly to the jawbone.
A microscopic biological fusion. The tooth becomes part of the skeleton.
And if you apply braces to an ankylosed tooth, it won't move. Instead, it acts as an anchor and pulls all the normal teeth out of alignment.
How do you even know it's fused if it's buried in the bone? The x-rays might not show a microscopic fusion.
Dentists use percussion testing. Once they expose the crown, they tap it with a metal instrument. A normal tooth gives a dull sound. An ankylosed tooth gives a high, sharp, metallic sound.
That metallic sound is the acoustic clue that the operation just hit a brick wall. So what do?
You pivot to extreme treatments, starting with surgical luxation.
Where they literally just grab the tooth with forceps and purposely break the bone fusion under anesthesia.
Yes, they shatter the osseous fusion to mobilize the tooth. And you have to apply heavy orthodontic traction almost instantly.
Otherwise, the bone heals right back and it fuses even stronger.
Exactly. If that fails, they might try distraction osteogenesis.
Which is moving the whole block of bone. You cut a block of jawbone with a tooth inside it and slowly winch the entire block of bone down.
The tension creates new bone behind it. It's a highly complex orthopedic technique.
But sometimes you just have to extract the tooth.
Which creates a massive problem for a growing kid because the alveolar bone needs a root to exist. If you pull the tooth, the bone collapses. By the time they're old enough for an implant, there's no bone left to screw it into.
So they use a technique called decoronation. They cut the crown of the tooth off, but intentionally leave the ankylosed root buried deep in the jawbone.
The body treats the root like its own bone. As the jaw grows, that buried root preserves the bone volume perfectly for a future implant.
That's incredibly clever. But the most mind-blowing surgical option, the texts detail, is autotransplantation.
A masterclass in human biological adaptability.
You extract the ruined front tooth, and then you take a premolar from the bottom jaw, which maybe had to be pulled for crowding anyway, and you transplant it into the front of the mouth.
The oral surgeon handles the donor tooth with meticulous care to keep the periodontal ligament cells alive. They place it in the front socket.
The body revascularizes it, the ligament attaches, and it integrates into the jaw.
And then a restorative dentist uses composite resin or porcelain to visually turn that pointy premolar into a broad, flat front incisor.
You end up with a fully vital, living tooth. No implant needed.
Reviewing all of this, the journey of the single tooth is just incredible. From being blocked by mutant supernumerary teeth to being tracked by parallax radiation geometry.
To being winched down by gold chains and shaped memory wires.
Yeah.
The sheer biomechanical warfare required to fix this is astounding.
It's an immense undertaking.
If you or your kids ever face a missing tooth, you now understand the extreme patience and engineering happening behind the scenes. You know exactly why the dentist might look at an empty space and a smile and say, let's just wait a year.
But, reflecting on the extreme nature of these interventions, the surgical luxations, the heavy traction, it highlights a fundamental limitation in our current paradigm.
What do you mean?
We spend all this effort using mechanical force to drag a stubborn tooth into place. But conditions like primary failure of eruption show us this is fundamentally a cellular issue. The texts actually mention the PTH1R gene mutation.
Right, the parathyroid hormone receptor gene.
Exactly. What if, in the near future, orthodontics moves away from wires and chains entirely?
No more winches.
What if we could simply inject a localized protein or a CRISPR-based gene therapy directly into the gums? We could chemically dissolve the ankylosis and biologically command the tooth follicle to just resume its own natural eruption.
We'd be transitioning from gold chains to molecular reprogramming.
Commanding the tissues without any external force. It's the ultimate biological solution.
That is a profound shift in how we approach human development. Something to really mull over next time you see the seamless symmetry of a fully developed smile. Thank you for joining us on this deep dive into the source material. We'll catch you on the next deep dive.